Welcome, everyone, to this deep dive into ear reconstruction. We're tailoring this specifically for surgical trainees, really focusing on what you need for board examinations. Let's jump right in.
Absolutely. The aim here is a really focused review. We'll hit the key anatomy, the aesthetic considerations, how to manage those acquired deformities you'll see, and the core reconstructive algorithms, sticking to the essentials.
Perfect. Let's start with the foundation, the cartilaginous framework of the auricle. How should trainees think about this structure?
Okay, structurally, it helps to think in three tiers. You got the central condylar complex, then wrapped around that is the antihelix antitragus complex, and finally, the outer rim is the helix lobule complex. Understanding how these fit together is, well, fundamental for any reconstruction.
Right, the three tiers. And the blood supply, always critical. What are key vessels trainees absolutely need to know?
The main player is the posterior auricular artery. It supplies both the front and back surfaces through perforators. You find these medially near the triangular fossa, symboconchae, cavum conchae, helical root, and down to the earlobe.
Okay, posterior auricular dominant.
Correct. Then you've got the superficial temporal artery supplying the lateral surface. And the really crucial bit for you to remember is the rich connection, the anastomosis, between these two systems. It gives great collateral flow.
That redundancy is key. And venous drainage. Does it follow suit?
It pretty much mirrors the arterial supply, yeah.
Yeah.
Posterior auricular and superficial temporal veins draining into the external jugular and retromandibular systems. Pretty straightforward, really.
Good. Let's talk nerves. Sensory innervation. What are the highlights there?
Okay, main ones. Great auricular nerve handles the lower lateral and inferior cranial parts. Auriculotemporal nerve takes the superior lateral aspect in the top part of the ear canal. Then the lesser occipital gets the superior cranial part, but the one to really flag is Arnold's nerve.
Ah, yes, the vagal branch.
Exactly. Branch of the vagus. It does the posterior inferior ear canal and the bottom of the conchal bowl. Clinically, you remember this because it's behind some referred ear pain, otalgia, and that cough reflex when you examine the ear canal.
And that explains why a standard ring block misses the concha and posterior canal, right?
Precisely. You need to specifically account for Arnold's nerve territory if you need full anesthesia there.
Okay. And lymphatic drainage. How does that map out?
It actually ties back neatly to the embryology, to the six helix. Structures from the anterior helix, tragus, helical root, superior helix, they drain forward to the parotid nodes.
Right.
And those from the posterior helix, the antihelix antitragus, lobule drain down to the cervical nodes. It's a logical pattern if you remember the origins.
Useful correlation. Okay, let's shift slightly to aesthetics. What are those key proportional relationships we aim for in reconstruction?
Well, you're looking for general guides, really. The ear sits about 1 ear length back from the lateral orbital rim. Superior edge roughly aligns with the lateral brow.
And to the bottom with the nasal ala.
Exactly. Height is typically around 5.5 to 6.5 centimeters in adults, with about 55% of that. Then there's the protrusion from the head laterally, about 1 to 2 centimeters.
Kind of tilt.
Yeah, two angles to consider. The incline from vertical is usually 21-25 degrees, and the whole long axis tilts posteriorly, maybe around 20 degrees on average. These are just benchmarks, of course.
Good benchmarks to have. Right, let's get into acquired deformities. Acute management first. Bites see a lot of those.
Definitely. Dog bites are probably the most common, especially in kids. The main thing you worry about is infection. So management is conservative debridement, loose closure, and definitely immediate antibiotics.
And what are we covering empirically?
You need cover for Pasteurella from dogs and cats, and Viridin strep if it's a human bite. So amoxicillin clavulinate is usually the go-to choice.
Makes sense. What about blunt trauma? Hematomas are common there.
Very common. And the absolute key is immediate evacuation. Get that blood out from under the perichondrium. Then you need a good compressive bolster dressing
Why worse?
to prevent reaccumulation. If that subperichondrial hematoma organizes, you get fibrosis, cartilage distortion, and that's how you end up with a cauliflower ear. Prevention is everything here.
Got it. Bolster dressing is key. How about lacerations, avulsions, amputations?
For straightforward, clean lacerations, keep debridement minimal. Just close the skin. Try to avoid suturing the cartilage itself if you can. It doesn't heal well and can cause issues.
Can only. Okay.
If you're planning a delayed reconstruction, definitely close the skin primarily to protect the cartilage. If you have a partial skin avulsion but the perichondrium underneath is intact, you can often reattach that.
And completely avulsed pieces.
Small ones, say less than 1.5 centimeters, if they're clean and you see the patient quickly, especially a child, within maybe 6 hours, you can consider reattaching them as a composite graft.
Worth a try. And for larger open areas.
Clean it well, debride anything obviously dead, then maybe some basotracin ointment and a non-stick dressing like Zeroform. The goal is just to keep it moist and clean, prevent desiccation before a definitive repair plan.
Right. Protect what's there. Moving on to thermal injuries, frostbite first.
Frostbite needs rapid rewarming. Use warm saline soaks. Think about antibiotics, maybe a fluoroquinolone. And in more severe cases, you might consider anticoagulation like heparin or dextrin to try and limit thrombosis.
And burns.
For ear burns, topical mafenide acetate cream is often used. Use non-compressive dressings. Let the eschar declare itself, then you can debride conservatively. Just watch out for infection. Pseudomonas is a common culprit in suppurative eschar.
Okay, good pointers. Let's switch gears to tumors. Benign ones first. Keloids are very common on the ear.
Very common, especially on the lobe after piercings. They're basically an overgrowth of scar tissue, extending beyond the original wound. Risk factors include darker skin types, trauma, tension, infection.
And notoriously difficult to treat due to recurrence, right?
Exactly. Simple excision alone has a really high recurrence rate, so you almost always need multimodal therapy. That might mean excision combined with intralesional steroids or sometimes with radiation.
Other options.
Yeah, steroid injections alone, cryotherapy, silicone sheeting, pressure earrings post-op. The best approach often combines several of these.
Multi-pronged attack.
Oh,
What about chondrodermatitis, nodularis chronica helictis, CNH?
right, CNH. That's that painful little nodule, usually on the superior helix, more often in men. Can sometimes look worrying, like a malignancy.
How you differentiate?
The key feature is often the pain, especially with pressure, like sleeping on that side. Treatment is typically complete excision. You need to take the lesion and the underlying inflamed cartilage down to healthy tissue.
And recurrence.
It can recur if not fully excised or if pressure continues. So ensuring pressure relief post-op, maybe with special pillows, can help.
Got it. Now, malignant tumors. What's the key message for trainees?
The ear is actually a really common site for skin cancers, surprisingly high incidence. Squamous cell carcinoma, SCC, is the most common, then basal cell BCC, then melanoma.
Anything specific about ear SCC?
Yes, important point. SCC arising on the ear seems to have a higher rate of cutaneous metastasis compared to SCCs elsewhere on the skin. So you need to be quite vigilant with these.
High index of suspicion needed. Okay, let's move into the reconstructive algorithms. How do we start classifying defects?
The basic classification is partial thickness versus full thickness. And then you define the location. Is it the helical rim, the superior third, middle third, inferior third, or the lobule? That classification really dictates your reconstructive ladder.
Right. So starting with partial thickness defects.
If the perichondrium underneath is still intact, you can often just use a skin graft, typically harvested from the contralateral postauricular area, good color and texture match.
And if the perichondrium is gone?
If it's a small defect, maybe under 1.5 centimeters, sometimes a wedge excision converting it to a full thickness defect might be simpler. For larger areas without perichondrium, you'll need flaps, local preauricular or postauricular advancement, or rotation flaps, sometimes tunneling flaps.
What about areas like the conchal bowl?
Yeah, for non-critical contour areas like the concha, if the cartilage is exposed, you can actually excise that cartilage down to the posterior skin, which is well vascularized. Then you can put a full-thickness skin graft directly onto that posterior skin. Bolster dressings are vital there.
Good tip. Okay, now for full thickness defects. Let's start with the helical rim.
Small defects, maybe less than 2 centimeters, you've got options. Under 1.5 centimeters, a composite graft from the other ear can work well. Or the anti-abutch procedure that's a classic, advancing the helix using a postauricular skin flap and some contracutaneous VY advancement.
And for larger rim defects, over 2 centimeters.
Then you're usually looking at needing cartilage grafts, maybe from the ear itself or ribs, covered with local flaps. Staged procedures become more common here, like the postauricular pocket flap, or Converse's tunnel technique using a contralateral cartilage strut and a staged flap. Tubed pedicles are another older option.
Right, staged approach is often needed. How about the superior third?
Again, small defects might be managed by just reducing the overall ear size, using Tanser's excision patterns. Larger defects often need contralateral cartilage grafts, covered perhaps by pericular banner flaps, or the valise handle technique, another staged approach.
Any single-stage options for larger superior defects?
You could use contracutaneous composite flaps from the contral bowl itself, like the anteriorly based Davis flap or the laterally based Ortocachia flap. For really big defects, you might be into costal cartilage frameworks covered with a temporoparietal fascia flap and skin graft.
Okay, complex options there. Middle third defects. Similar principles.
Pretty similar, yeah. Small ones, reduction. Larger ones, maybe a postauricular island flip-flop flap. especially useful for chondral defects in this zone. Contralateral composite grafts can work. Converse tunnel again, or Dieffenbach's staged flap is also possibilities.
And the inferior third.
Often reconstructed using superiorly based, folded over flaps, which usually need a cartilage graft inside for support. Or you could use a modified valise handle technique down there.
Finally, the earlobe. How do we reconstruct that?
Lots of options depending on the size. Contralateral lobular composite graft works for smaller defects. Transposed postauricular flaps are common, sometimes combined with a superiorly based anterior skin flap. You can rotate chondrocutaneous flaps down, maybe including some chondral cartilage to prevent contracture if needed.
And fixing cleft earlobes from earrings.
Standard techniques there are wedge excision, maybe with a Z-plasty to break the scar line, or sometimes a rolled flap technique if you want to preserve the piercing channel.
Okay, that covers the main defect locations. Let's briefly touch on replantation and banking. Is replantation often feasible?
It's technically demanding. You need a suitable vessel for microvascular anastomosis, usually the superficial temporal or posterior auricular artery. Venous anastomosis is harder and often not possible, so leeches might be needed post-op.
But the result?
If successful, it generally gives the best possible aesthetic outcome, better than secondary reconstruction. But it's not always an option.
And banking, if replantation isn't possible.
Banking the salvaged cartilage is an option, yeah. You can place it under the bustauricular skin, maybe in the temporoparietal fascia, or even remotely like the forearm, though success is quite variable. Maladic's pocket principle is well known, dermabrating the cartilage and burying it.
Any specific techniques?
Baudet described fenestrating the cartilage, reattaching it loosely, and covering it with a postauricular flap. One key point, preserve the temporoparietal fascia flap if you can during the acute phase. Don't use it just to cover a banked piece. Save it for potential secondary reconstruction.
Wise advice. Lastly, total ear reconstruction. What are the core principles?
What boils down to framework and cover. The framework is usually carved from autologous costal cartilage ribs, 6 to 8 typically, or sometimes a synthetic like porous polyethylene medbore. This framework, often templated from the opposite ear, then needs vascularized soft tissue cover. The workhorse here is the free or pedicled temporoparietal fascia flap, covered with a skin graft. Tissue expansion of the local skin is another covering option.
And if framework reconstruction isn't suitable,
then osteo-integrated implants to retain a prosthetic ear are a very viable alternative, giving good results too.
excellent overview. So to wrap up, what are the absolute must-know takeaways for someone heading into their boards?
Okay, key points. Remember the dual blood supply, posterior auricular and superficial temporal, and their anastomosis. Know Arnold's nerve and its clinical implications. Pain, cough, anesthesia gaps.
Right.
For lacerations, think skin-only closure initially. For CNH, complete excision including cartilage is key. Keloids, think multimodal therapy from the outset.
Definitely.
Classify the defect accurately, partial versus full thickness, and location as this guides your whole algorithm. And finally, remember that microvascular replantation, when feasible, offers the potentially best aesthetic result, though complex reconstruction gives excellent outcomes too.
Fantastic summary. Hopefully this focus run-through helps solidify those core principles for ear reconstruction as you prepare.
Absolutely. Consistent review of these fundamentals is crucial. Good luck with the exams.